Can you hear me?
A very good morning to you.
Good morning. Is that Rochan?
Yeah, that's me, and nice to see you. So tell me, what are we doing?
Yes. Oh, yeah. See, I'm at the Kokilaben Ambani Hospital in the cath lab. We are lucky that we have a biplane cath lab system here. And we've got a case which is very interesting from the point of view that this is about a 56-year-old lady who would complain of giddiness, especially while looking up. And when she would stare in the different directions, she would get blurring of vision. She has already undergone a carotid stent done for the left common carotid artery origin. Primarily, she is a case of aortoarthritis. And as all of us know, it is an autoimmune disease. And in her case, bilaterally, the subclavian, both the carotids were occluded. There was a tight stenosis of the left subclavian, left carotid artery, which I had dilated and stented about 7 years ago. And this time again, she's come back with a similar complaints.
Okay.
At this point, Rochan, you can take over for the aortoarthritis, what we need to investigate.
Yeah.
And
Yeah, thanks, Vimal.
so I then will show you. Yeah, please
when
do
you
that.
have the
Meantime,
angios
I'll
for
start
us,
with the case.
Just show it to us. Aortoarthritis, as
Yes.
we all know, is not the usual condition because more common in these areas, Southeast Asia, Japan, India. And the disease is kind of recurring, relapsing, and the stenosis is basically a thickening of the wall of the artery. And it cannot be exactly treated like atherosclerosis because the disease is a little bit different. Occurs in younger patients, mostly women, and very commonly involves the branches of the aortic arch as well as the renal arteries. And we often see patients presenting either immediately around or after a pregnancy, sometimes in later middle age. The patients who present with neurological symptoms generally have occlusions and involvement of more than one artery. Frequently, you end up with a situation that Dr. Vimal was mentioning. What I gathered from what he told us is that basically this patient's brain supply is hanging by a thread. That's a single stenosed carotid artery. And here we can see the angiogram which is coming up. Oh, he's already got a catheter across the left carotid. And you can see the stent here. The stent is in the left common carotid.
I will show you the... Yes, actually, Rochan, now I'll try and show you the angiography here.
Yeah, that would be nice. Yeah.
Now, yeah, before we took up the patient, we got her creatinine done, which was normal. And we also did her CRP and ESR.
Yeah.
They were both normal. So when that happened, we knew that this is not an active inflammation now.
Okay.
And we could attempt an intervention in this patient.
Yeah. So this
as we know, surgery is definitely out of just not possible to do a surgery in this patient.
Yes. So the
we did the CT angiography on this lady. However, the camera was not working, so I could not show you, but the CT pictures are there with us.
Okay.
And then we did the angiography on the DSA here.
Yeah, I can
so
see
I will try and show you the DSA pictures. Can I just show the pictures for the angiography first?
Sure.
Yep, so angiography dikha do, and we can remove the sheath.
Oh.
This is the intracranial. As you can see, the whole intracranial circulation is supported by the left carotid artery.
Yes, this is very critical, Vimal. Why you have done this is very, very important.
Yes, because this is necessary to demonstrate, and any kind of event, neurological event, could be a disaster in this patient.
Yeah. So you're looking at a single vessel
Now the
supplying the
second
entire
point,
brain.
that's right. Go back. We'll try and show you the stenosis and we'll try and show how we got the catheter inside. No, next, previous. Here is the angiogram there. You can see that faint shadow within the stent where there is a narrowing.
Yeah.
This was well demonstrated on the CT angiography. And we like to see the cross section on the CT in these patients. Previous, go on the previous pictures. Back. Yeah, this image shows better. You can see that
Yes.
narrowing in the stent.
Yes.
Now this being an inflammatory condition, the intimal hyperplasia is quite heavy in these patients.
Hmm.
And can you go ahead? I will try and show you how difficult it is to cannulate this artery once the stent is hanging in the aorta.
Absolutely.
You can
and
see
you would
we
do
are,
that.
we've got a, yeah, we have taken an 8 French guiding sheath, a multi-purpose guiding sheath,
Mhm.
and 125 length multi-purpose diagnostic catheter 5 French. And there we are struggling. I have my colleague here, Dr. Gordon. He is very good with his carotid catheterization. And the picture that I'm trying to show you on the DSA, see the struggle that is there to get the wire across. You don't want to go through the strut, otherwise your balloon will not go up on the wire.
Yes.
So,
So-
we are now trying to catheterize the, yes, Rochan, you have question?
Yeah. So two things. Firstly, I think we can
Yes.
tell the audience why this stent is hanging out in the aorta, and secondly, what was your
Yes.
choice of catheter dictated by?
Sorry, choice of?
So first one was why is this stent hanging into the aorta and how that added to your problems now? And second was why
Yes.
you chose this particular catheter set that you have chosen, an MP guide cath and an MP 125
right.
centimeter. That might be interesting for
That's
the
right.
audience to know that.
See now right, we keep the stent hanging because this is an aortoarthritis. So there is definitely an inflammatory thickening in the aorta which extends into the origins of these great vessels.
Yes.
And therefore you need to have a stent slightly hanging in the aorta, so there is a direct flow from the aorta through the stent.
Yes. Perfectly. So that you don't get a
Now the-
osteal
Yes.
occlusion after you stent.
Yes, occlusion, yes.
So
And we decided to use this system because we have a lot of support with this and the flexibility of a 5 French catheter.
yeah. So
We
you're using
used a terumo
a
wire to
biaxial
cross the
system.
lesion.
Yeah.
Yes. And now you can see the catheter going up on that guide wire. So we got into the external carotid, parked our diagnostic catheter in the external carotid. And now we are taking a support wire which will help us cross this lesion. Can I go back? Now you can see that my wire is getting out into the external carotid. You don't want it to dissect.
Yes.
We are getting the diagnostic catheter out. Now, the question that comes up is how do you treat the in-stent stenosis?
Hmm.
Sir, मेरे को Y connector
So
दे दो.
this is a particularly difficult situation that we are facing here, and for the audience, I don't know how many are familiar with aortic arch and carotid interventions. What he has shown you makes it look easy. Getting into a stent which is stenosed and projecting into the aortic arch where you've got two bends facing you immediately is quite difficult. And I think this has been very smoothly done here. And the other point that he made of the tip of the catheter where it's parked. Now when you are going to exchange and the tip of the guide wire is going to move, the last thing you want is the guide wire tip moving in against the wall of the internal carotid artery.
Pressure.
If you dissect it or even cause a spasm, the patient will have a terrible stroke. Because I hope everybody realizes this is the only blood supply to the brain. So this is, at this point of time, we are safe, we've got a wire across, and I think they are now proceeding with the next step. So you had the statement about the in-stent restenosis, Vimal.
That's right.
Huh.
See, now this is again an inflammatory condition. And now what do we do for these kind of in-stent stenosis? Balloon dena. Ah, Manish
Yeah,
bhi aa gaya.
that is the bugbear of endovascular work in general, in-stent restenosis. And this particular case
Yes.
even worse, because this is inflamed, thickened
Yes.
tissue. There is no plaque.
Right. So
So that much more difficult to handle.
Yes. The issue now is in-stent stenosis. Do we put a stent? Do we balloon it? Yeah.
Yeah, this
Number two is, should we put a cutting balloon? And obviously drug-coated balloon are another things that we are talking about.
Yes, osteoarthritis actually the data
Yes.
for drug eluting and drug coating is very, very sparse, because obviously disease is not common in many countries, and even here the number of patients who undergo treatment is not that large. So I think that question will remain, Dr. Sharma, I think that question will remain open as to whether drug eluting balloons. But going theoretically, since your process is one of cell division and proliferation, theoretically it should help, but we don't really know. So yes.
Yes.
Your other choice was a
actually
cutting
there is
balloon,
nothing
right?
data available. Yes.
So what about cutting balloon? What do you think?
You know, I have used a cutting balloon in a patient with osteoarthritis. And what happened was, probably we cut the tissue, like a crumbs of cake. And the tissue went up into the central circulation.
Oh, you had an embolic episode after that?
Yes, we had an embolic episode, and that was a problem for one of the patient.
Right, that's...
So we are not too keen to use a cutting balloon in these kind of patients.
Yes. Apart from which there is always the possibility of perforation with a cutting balloon. So that would be disastrous in this scenario. You're right next to the aortic arch. It will be difficult to handle.
Chalega, aega. Yes, dalo. Niche dikhao.
So you can see how carefully the manipulations are done in this territory. You don't want the guide wire tip moving up and down. You have to see the entire course.
We have a stiff wire in the external carotid.
We didn't hear that clearly. What wire do you have?
The guide catheter. We have a Amplatz stiff wire here.
An Amplatz
Not
wire.
a real wire that you would use. Yeah.
Okay.
Normally we would not use this wire in the carotid territory.
Yes, I mean, classically in the early days
but in this,
when you had started your carotid program, Vimal, I remember we used to use an exchange system with a wire parked in the external carotid to get the long sheath up. Currently, of course, we tend
now
to
you saw that I have Dr. Manish, he is a master neurointerventionist.
Yes.
And we are lucky that we work in a team. And Manish was here, and he's the one who got the balloon inside.
That's nice.
See, the most important thing was we didn't want the balloon to get stuck in the strut of the stent.
Yes, going across the struts.
So when you first get, yes. So when the wire goes up, you got to be careful that you do not go through the strut.
Yeah, this is a situation
So
where the
over
wire,
the wire
has to
once,
be through the lumen, true lumen.
Yes, yes. And now you can see that we've got a balloon which is 7 mm 40.
What
because
balloon
the
are you
previous
using
stent
here,
is 8 mm. We are using a Armada.
Okay.
035 compatible, 135 length. And the balloon is 7 by 40.
7 by
we
40
will be
Armada
inflating
balloon.
now. Yes. Since we are in the origin of the carotid artery, we will be, and being the single vessel which is supplying the brain, we will not keep there is a bubble in the balloon. Okay. We got to be careful
where the waist of the balloon
ruptures,
is.
especially.
That's where the tight narrowing is.
Yes.
And we're trying to get the maximum
Yes.
possible lumen out of this angioplasty. At the same
Yes,
time,
we can go up
this
to
is a
10.
high-risk procedure because of two reasons. When the balloon is
Yes.
inflated, the blood supply to the brain is cut off. Secondly, if you overinflate and rupture this artery, that's a very, very bad situation to be in because this is inside the thorax.
Yes.
Very difficult to control. So I can understand, Vimal, that the stress levels must be high up there. So,
Right. You know, and the regular carotid, we have this worry about the baroreceptor getting stimulated,
yes.
getting hypotension, tachycardia, bradycardia.
Absolutely.
We do not get any of those things here.
Yeah, because baroreceptors are
Because
near
we
the
are way
bifurcation.
down.
Yeah, that's right.
Yes. We are making a dye injection to see what has happened. I think we'll have to keep the catheter up probably.
Flow
To
seems to have
demonstrate
improved.
that, I think our dye, yeah?
Has the flow improved now?
I'll have to take the catheter up. Now what we are doing is, we are over the balloon and the wire, we are taking the guide catheter at the ostium.
Yes. This is a very important step because when you remove the balloon, you have to be very careful in this situation where the stent is there. If you manage to somehow engage the stent in the balloon, then you might have a problem there. That's why the guide cath is being taken up, and this is a difficult process. It's a stiff device being taken up.
Now you can see that there is definite improvement in the caliber.
Yes.
What we plan to do now, Manish? Yeah.
At the origin still
Pull it
looks
back, yeah.
residual quite a bit.
Yes.
But then
That's right, sir. We are bringing the balloon back
Yeah.
repeat dilatation plan?
and we'll dilate it over there. Yeah, sorry?
You're planning a repeat dilatation?
That's right. We're going to do that. And we're going to go at a little higher pressure also.
Okay.
Yeah.
In this case, keeping the balloon hanging out in the aorta is not a worry
Yes.
because the diameter is of the aorta is much bigger. You can see that a kind of waste coming up on the balloon.
Yeah.
We are at 4 atmospheres, going to 6,
Okay.
10, going up to 12.
And
Yeah, we have gone up to 12 and we're going to deflate it. Huh? Huh. We're going to deflate it fast, we'll not keep it long.
yes, because you're going to cut off the supply, so
That's right. At this point of time, we need to inquire with the patient of any symptoms or anything.
yes.
ये पैर हिलाओ आपका? Yes.
You're
दोनों
asking the
हाथ
patient
हिलाना.
to move their limbs to make sure there's no neurological problem after the inflation. If there's any neurological problem
Yes.
occurring, then we'll have to look at why very rapidly.
Yes.
In this territory,
And very important, you know, previously we used to have this duck, squeaking duck.
yes, in the contralateral side.
But in this patient,
yeah,
but in this case, we have to keep it on both the sides.
yeah, because every part is being supplied by
Because
this
this-
artery. So
I think,
I
we
think
need
you have
to
a
go one
better
more.
situation now.
We have a better, but we still want to do one more, right? You
Yeah,
want to do
because-
8 or do you want to 7 is enough? 8? Can we get a 8 balloon? Okay. Cutting nahi. Dangerous. Cutting, I would, you know, we are discussing amongst us whether cutting any role,
I think
but I would be little worried on cutting.
with the 7 millimeter, I think you managed to get almost a 4 or 5 millimeter lumen there. I don't know if cutting balloon will really help
That's
at
right.
this point. Perhaps a bigger balloon or a higher
I think
pressure
so.
balloon.
Yes.
What was the size of the original stent, if you have that information?
8 mm?
8 mm. So the original stent is 8 mm.
I think this was a balloon mounted, yeah, balloon
Yeah, it
mounted
is-
837 or something like that.
Yeah, is that a scoop? So now we are limited to 8 millimeters because if you cannot go above that. So,
Yes.
and you can see the narrowing is there because the tissue which is inside the stent, the restenosis part, that is not going to disappear very easily.
See, this is an inflammatory fibrotic material.
Yes. So,
And this is one thing we are always worried about in inflammatory arthritis, because once restenosis occurs, it definitely creates a lot of problem for these patients.
Yes,
And would require multiple dilatations over a period of time. So we are now taking 840 balloon and would try and inflate up to 10, 12 12 atmosphere pressure.
same Armada balloon?
No, we have taken a Cook balloon this time.
Okay, advanced LP.
This is, yeah. Yeah. नहीं उसको डाल दे जाएगा जाएगा yeah, wire tip is moving there. Yeah, we got it.
Yeah, we have to be very careful about that wire tip.
External में किस में
the problem with this intervention
you know what?
is
This
the end organ is really in a precarious stage right now, so one doesn't want any problem at all.
Yes. There is a soft loop up there in the stent. We can dilate it here. So we're going to dilate the ostium more than the... Yeah.
Yes.
Beyond that, we feel that that is quite good. You know, the original symptom on this patient was just because of hypoperfusion rather than an embolic.
Yes, absolutely. This is what is different between the normal carotid atherosclerosis and aortoarthritis. Aortoarthritis is a hemodynamic problem
That's right.
more often, and atherosclerosis is generally an embolic problem. So the treatment is quite different. The philosophy is
Right.
quite different.
Yes, you can see that we are having a tight narrowing there. This is an 8 mm balloon. Up to 10 atmosphere, we are going up to 12.
Could you tell us how long
14
can
also
you,
we've gone up to.
how long can you plan to keep this inflated?
Inflation? No, I think we are keeping in seconds, yeah.
Yeah, okay.
She's tolerating it though. But I don't think so we should keep it too long, yeah. Somewhere she will definitely have a hypoperfusion
Yes.
injury there. So we'll have to be a little more cautious. I think we are definitely not gearing up for another stent here. I know some people might be thinking stent within stent, but that will induce much more inflammation.
Yes.
And the next time when we go in, we'll have more problems. I think it's better to keep on dilating this lady.
Yes. Yes, I would agree with that with aortoarthritis because it's a recurrent disorder. So, I mean, the episodes of inflammation and fibrosis will keep cycling. So, stents
That's
don't
right.
really improve the long term. Oh, that looks better,
Just
definitely.
Not getting a good picture here, though. Look better, though. Definitely much. I'm sure symptomatically she will improve. और क्या करना है?
So Vimal, I think your point would be that the appearance is not as important as the flow in this scenario?
Yes, that is true. And what we're going to do now, we remove the balloon and we take a look at the artery again. Maybe we'll get a stent, diagnostic catheter. I mean, this. Can we just fish mouth it over the balloon, partially inflated, just to get a good image? Just a minute. You know what we are trying to do? Inflate the balloon a little bit
So that the backflow
and
is
try
more.
and get my guide catheter up, guide catheter a little bit inside over it,
Yes.
if it can go over it. So that will give me the picture a little better then.
Yes.
Okay, okay. I think I'm gonna. Now we deflate the balloon and get the balloon out. No, the balloon pulled the guide catheter also back. But yeah, it's again taking a position. Fair enough, we'll see that.
It's like time for break.
We'll take a run now. Sorry?
Yeah, we were just looking at the image, and I think it's important
Yes.
what you mentioned, that you're looking at the flow and not at the appearance of the lesion.
Yes.
Because this is never going to
Yes.
be clean looking like a stented result. So, but that doesn't matter.
Right.
Okay. So,
Okay.
what
So
what
we're
kind
going to
of
take a run now.
yeah? Let's see the
Yes. सांस बंद रखिए, सांस बंद. Oops. I think the balloon
Yes.
is creating more. We get the balloon off. Yeah.
So your
can
narrowest
get the
point is
balloon
right
out.
at the ostium.
Yeah.
It's difficult.
Yes.
But still, it
Okay.
looks like your flow
We
has
withdraw
definitely
this.
improved going by the earlier runs.
Yes.
Even though
It
the
looks
lesion
better.
looks like it's recoiled a bit, your flow has definitely improved.
Okay. We are getting this balloon out
Yeah. So you
because with the balloon within the guiding sheath, we are not getting a good pressure of injection.
yeah, yeah, okay.
Yeah, we are out. Otherwise, she's doing fine. The both hemodynamic as well as neurologically,
Yeah.
she's okay.
We're able to see that on our screen. The hemodynamically, the patient is
Yes.
doing fine.
Right. Now we are just trying to do a fresh angiogram.
So,
Let us see this picture now. Possibly we will get a better picture with the balloon out of the catheter.
yes.
The pressure of injection would be definitely better. सांस बंद कीजिए. There it is.
Oh, that's very nice actually. It looks much better. You are absolutely right.
Yes.
You definitely got a very
Yes.
good result.
Yes. And more important now is that there is a thought process whether to try and open up the right side also. You can see the stump of the
Yes,
innominate
the
there.
innominate there.
We have attempted before, yeah, but we could not succeed crossing it. We can get the wire out.
I guess the patient's symptoms will
Now
decide.
we'll see the intracranial also with this. Wire
Yes,
को
very.
नीचे ले ले.
Very much need to see that.
बस हो गया, इधर
So
ही रख
at the
देते हैं.
beginning and end
Right?
of the procedure, whenever you are in the carotid territory, you have to see the intracranial circulation in both the AP towns and the lateral views, and look at the perfusion of the areas. And any change in that has to be investigated very thoroughly. This is very critical. And if you don't look up, you get into trouble. You have to look up. That's the town's view.
Yeah, this is the town's view. We have the biplane, so we're going to do the shoot in the biplane. In this, you have to adjust both the lateral and the AP view the way you want it, and then take a shoot. Yes. Okay. In these patients also, the antiplatelet therapy remains the same. We start the dual antiplatelet
Yes.
minimum 3 days before the procedure, and will continue.
Yes, I believe the idea is while the intima is damaged, you need to have them on antiplatelets till the intima reforms
That's
properly. Right. And what about steroids?
That's
Is this
right.
patient on steroids or has been on steroids recently?
Not really, because her inflammatory markers were all within control.
Okay.
So there was no need for that. In fact, steroid was leading to diabetes, which was going haywire.
Okay. So steroids were stopped. So
Yes, so steroid was stopped actually.
okay.
We are taking the run.
Oh yes, you much better seeing the
This
vertebral
run
now.
is,
The basilar is seen much
yeah,
better
is
than
it?
before.
Let us see that.
Your flow has definitely improved a lot.
Yes, yeah, vertebrals are definitely seen better
The entire
compared
brain
to
from
the
this
previous
artery.
picture.
Okay.
Yes, fully supported by this.
This, I think if your patient
This
is
patient
asymptomatic
we
now,
will
you'll
be
be really rewarding procedure.
Yes, we'll ask her to move a leg. दोनों पैर चलाइए जरा, शाबाश, दोनों हाथ चलाइए.
The patient has been asked to move all 4 limbs.
नाम बताए,
And
क्या नाम है?
they'll examine the patient
अच्छा,
neurologically
आंखों में
for
कोई
the higher
problem या
mental
कुछ?
functions, speech deficits, anything at all.
ठीक है.
I think
Okay.
include now. I think
So yeah,
we
she's
want to go
managing
for-
very well.
So at this point, you're not doing anything further?
No, we are done with this.
Okay.
Any questions from the audience? We are ready
Any
to
questions
take it.
from the
Yeah.
audience? I think that was a beautifully done procedure. You made it look simple. You made
Thank
it look
you very
really
much.
simple. But believe me, it's a
Yes,
very stressful
There are
procedure.
few steps which were difficult. Yes. And you know, you have a good team. Manish is there, Gordhan is there. This one is there. Technology team, Anil and the full gang is here. The nursing staff is here. So
Yes.
everything is looking good. Thank you.
Thank you.
Oh, okay. They want me here.
Excellent.
Yeah,
excellent
thank you
job.
very much. And it was nice working for you.
Thank
And
you
see
so
you
much.
guys next time somewhere. Thank
Okay.
you. Thank you.
Thank you.